have with me Colonel Vijay Sharma, who is again a cornea specialist in charge at Calcutta Army Hospital. Dr. Namrata Sharma will be joining soon. Dr. J.K. Reddy. Dr. J.K., are you there? Okay, he will be coming soon. Dr. Swapna, I can see her. If you can please come up on the dais. And Dr. Swapna Nair. Dr. Arun Jain will be joining shortly. And we have Dr. Jagruti Jadeja. Can you please come up, please? So the idea is this, that there are many cases of keratoconus wherein you don't have you put up yet? Okay. So there are many cases of keratoconus wherein we are not able to decide what to do, when to do, what all things should be done, whether we should cross-link all the cases of keratoconus, what modality should be used. So that is why we should have, sort of an interactive session wherein you can also put in your viewpoints and we will discuss on what exactly should be done in different scenarios. So we begin with the first presentation, and that is by Colonel Vijay Sharma, who will be talking on should all cases of keratoconus be cross-linked. So that is the idea, to know whether every case who comes with a diagnosis of keratoconus should be cross-linked or not. Dr. Vijay Sharma.
Thank you, sir. Good morning, everyone. So I'll be discussing about should all keratoconic corneas be cross-linked and some basic concepts about the cross-linking. It was Wolensak et al. In 2003 who, while working at Technical University of Dresden, they came out with the corneal cross-linking, and it was named as Dresden Protocol. Their technique was named as Dresden Protocol. Now, what they did was they subjected an actinic cornea to a photosensitizing dye, that is 0.1% riboflavin, every 5 minutes for 30 minutes. After it was saturated, then it was exposed to a UV radiation of 370 nanometer with energy of 3 milliwatt per centimeter square for 30 minutes. Total 5.4 joule was delivered, and over a period of time, it leads to increased number of cross-linking, the covalent bonds between the adjacent collagen fibrils. This results in strengthening the corneal tissue, and also it retards or it stops the further progression of corneal ectasia. So after this Dresden protocols, over a period of time, many variations to this also came into being. The problems were, this is one of the most standard and most efficacious of the corneal cross-linking, but the duration of the procedure was quite long. It used to take full 1 hour for the patient in the OT to complete the procedure. And also it was an epi-off type of corneal cross-linking. So it used to be cause some amount of pain in the post-operative period. So then epi-on corneal cross-linking was tried, but the efficacy was not found to be as good. The main changes that came into the protocols were basically directed at introducing riboflavin into the stroma, or decreasing the total time for the cross-linking. So for decreasing the total time for the cross-linking, the accelerated corneal cross-linking came into being. But accelerated cross-linking, when the energy was delivered at a larger amount of energy was delivered for the shorter duration of time, it led to complete oxygen deficiency at that level, and the procedure became less efficacious. So that is why some oxygen supplementation have been described after that, and also pulsing the radiation was also is also being practiced now quite frequently, which will be covered in subsequent talks by the speakers. Iontophoresis was basically by delivering a low intensity electric field created. The riboflavin was penetrated. It can penetrate through the intact epithelium and reach the stroma, and then the corneal cross-linking was done. So all these procedures gave new dimensions, and also various new indications were included for the corneal cross-linking. In addition to ectasias, primary ectasias such as keratoconus and PMD, the secondary ectasias such as post-LASIK ectasia or non-ectatic disorders such as infectious keratitis, where a PAC-CXL protocol is followed, or a bullous keratopathy, chemical injuries, and TMD, all these cases the corneal cross-linking could be done. Some additive, it is also being done as an additive procedure along with a smile or LASIK as smile or LASIK extra, with a PRK as in Creighton protocol, with PDK as in Athens protocol, and also it can be combined with various intracorneal ring segments. Now, there are two main prerequisites as of now for corneal cross-linking. One is the thickness of cornea. For isosmolar, the thickness should be more than 400 micron, and for hyposmolar, the thickness the cornea which is between 350 to 400, that can be cross-linked. And another criteria which is important is a keratoconus progression. Now, over a period of time, various protocols have been described, starting with the Dresden, where they included the patients who had increase in Kmax of more than 1 diopter, or patients who self-report the deterioration of visual acuity, or if there is a need for contact lens fitting more than once in 2 years. Then these got modified over a period of time. In 2015, Gomes et al. Said that at least two criteria, one is progressive steepening of anterior surface and posterior surface, and the corneal thinning. So any two of these criteria, if they are present, then the individual should be cross-linked. So documenting the progression is important, but also they gave some exceptions that where there is a perceived risk of progression of keratoconus, in those cases you can go for corneal cross-linking without any documentation of keratoconus progression. So what if there is no documented progression? If an individual comes to you like this with one eye having a corneal hydrops, another eye having advanced keratoconus, but within the range of corneal cross-linking, then you do not need to wait for documenting the progression. This is the op scan of the same patient. In the right eye, nothing is recorded. In the left eye, the thinness PAC is 399. You can straight away go for corneal cross-linking rather than waiting for documenting any progression. So similarly, this patient, as you can see, the thinness PAC in this case is 355. So if you wait for any progression or documenting keratoconus progression, then it will go beyond the safe limits of the corneal cross-linking. So in these cases, you can go for corneal cross-linking straight away. In this patient, the PAC is good enough, Kmax is not very high, so you can wait for documenting any progression of keratoconus. And if you document any progression over say 3 to 6 months period, then you can go ahead with the corneal cross-linking. In this patient, one eye is 411, other eye is 530. So you can go for a isosmolar cross-linking in the right eye and wait for progression of keratoconus in the left eye. This is a Cyrus photograph. So in this, you can see in the left eye, it's already between 350 to 400. So no need to wait for any documenting the progression. You can straight away go for cross-linking in the left eye, followed by the right eye. So these factors you need to consider whenever a cross-linking is being done. And these are the various protocols which are followed with regard to Riboflavin delivery, the UVA amount of exposure, and oxygen delivery. Thank you.
Thank you, Dr. Vijay. It was very nicely and very crisp presentation that in what cases you should do cross-linking, wherein you should wait for documentation of progression, wherein you should not wait for a proper documentation when you already see that it's already advanced in the other eye, somebody has developed acute eye drops, etc. All these factors are there wherein you can directly go ahead and do cross-linking. Anything, any age-related criteria which will you consider in, waiting or doing directly?
In younger children, usually the risk of progression is quite high, and in younger children, but the problem is then you may require general anesthesia. So you have to balance both the things.
Absolutely.
If you can, you have to balance both the things for the kid. if you're documenting and it's progressing very fast, then you can go for early corneal cross-linking in children.
Yeah. Another thing which I would like to, hear from you is that somebody who is coming for the first time to us in the OPD with, sort of advanced keratoconus, 424 thickness, etc., who is 430 microns or 440 microns. Somebody who is 35 years of age and coming to you directly, or somebody who is 15 years or 18 years of age coming directly to you. So, in which condition you would like to wait, and which condition you would like to go ahead directly with cross-linking? That is one thing. And another point I would like you to emphasize on, in children, if you have VKCs, then, whether we should go ahead directly or maybe treat VKC for some time. Because the outcome of cross-linking may not be the same if somebody is having VKC. So that is something which we all should consider. A child with a VKC should be treated first, because the outcome of CXL is not that great if somebody is having VKC. But and somebody who is, say, 18 years of age coming to you for the first time with a corneal thickness of 440, 18 years of age, you may consider, if the other eye is having all those problems which Dr. Vijay was telling. Somebody who is 35, 38 years of age with that much of thickness, one may consider waiting and seeing whether it is progressing or not. So, I mean, we have to weigh the benefit, we have to weigh the chances of progression which is there or not. All these factors we have to think. Any comment?
Yeah, I would like to know, I mean, how long, what's your criteria for repeating CXL in a patient that has progressed in spite of CXL, let's say, done, or is there any you wait for? Is it the same as the primary criteria?
Usually, you can prioritize it as per the individual. If you're finding that keratoconus is progressing very fast, then you need also to know that is there any other offending factor that is causing this keratoconus to progress very fast. Like sir told, in VKC, if you do not treat VKC, individual keep on rubbing and keratoconus will keep on progressing further. So all additional these things need to be treated. Criteria, otherwise we follow the same criteria. And there is no fixed criteria for repeating the CXL, but you can prioritize as per individual requirements.
Thank you. Is there any question from the audience? Now I'd like to invite Dr. Rajesh Sinha, who would be talking about CXL in thin corneas and oxygen supplementation, supplemented CXL, as a continuation of Dr. Sharma's talk.
Thank you very much for being a part of this course. I'll be talking about another condition which is unique. We all know that cross-linking is an established modality these days for halting the progression of keratoconus. But then there are certain issues. One issue that was very nicely discussed by Dr. Vijay Sharma, that whether we should do cross-linking in all the cases, in which condition we should directly do, in which condition we should wait for documentation of progression. Another issue is in thin corneas. If the cornea is thin, if it's less than 400 microns, then there is risk of damage to the endothelium by UV rays. So, what shall we do? The idea is to have arrest of progression and also protect the endothelium. So both the things should be done, and that is the main aim of having, to discuss this or to present this topic. So there are various ways people have tried to increase the gap of UV rays from the endothelium. And one of the ways is to swell the cornea by using hypoosmolar riboflavin. Now, another method is you can put something on the cornea like bandage contact lens or any smile lenticule or any lenticule, so that the gap increases. People have also done, somebody who is having just 400 microns of thickness with epithelium, people have done transepithelial so as to do it. So I'll be discussing about pros and cons of each procedure and maybe some additional procedure that we have tried. So hypo-CXL is something which has been established initially. Farhad Hafezi gave the concept of hypo-CXL. The idea was this. The idea was this, that the gap between the endothelium and the UV rays, which is getting focused on the surface of the cornea, increases. So people have tried that, and there is some effect definitely of hypo-CXL, but it cannot be compared with the conventional CXL. The result is not that as good as conventional CXL. That is the result of most of the studies. Because there is a paradox, you are swelling the cornea, increasing the gap between the collagen fibrils, and again want to compact the cornea by cross-linking. So both don't gel together, and that's why the results are not as good. But yes, in some conditions you can do it because there is some result of hypo-CXL. Then another group started using bandage contact lens to increase the gap between the endothelium and the UV rays. The point is that once again you can do cross-linking in these corneas by use of bandage contact lens. There can be some effect, but the effect will not be as good as conventional cross-linking. Why? Because of two reasons. One, that cross-linking works mostly in anterior two-thirds of cornea, and you are putting a bandage contact lens, plus there is a precorneal tear film, and all these part you are going to discard in the post-op period. So the anterior two-thirds of cornea, which is getting effect, part of it is being discarded in the form of removal of bandage contact lens. So again, the result may not be as good. The second issue is that precorneal tear film again interferes with the passage of UV rays. So these two factors have ruled out or maybe have shown that the results are not as good as conventional cross-linking. Then in order to reduce the gap between the contact lens and the cornea, people have used SMILE lenticule, because lenticule falls straight on the surface of the cornea. There's no tear film between the lenticule and the cornea. But again, there will be some result, but part of it is being discarded, and as we know that the corneal cross-linking works mostly in anterior two-thirds of cornea, it may not work. People have done transepithelial again with limited effect. And people have also done many types of procedures like crisscrossing of epithelial debridement so that there is some riboflavin penetration. But again, it has been seen that the demarcation line has not been seen under the area where epithelium was not debrided. So we started this study, and now it's about almost 4 years or so. We have modified the study as well. Started doing intrastromal lenticule implantation, and that is a hyperopic lenticule implantation. We create a donor lenticule, and then we ablate the central part of the lenticule to create a negative meniscus lenticule. And then we create a pocket. I'll just show it in a video. We create a pocket in the cornea with the help of femtosecond laser. So femtosecond laser is used to create a pocket, and you dissect it and then put riboflavin in the pocket. And putting riboflavin in the pocket, it really increases the penetration very well, and it goes on both sides of the stroma, in the cap as well as the bed. And then after that, you leave it like that for 2 minutes, and then you put this lenticule as well, which is again soaked in riboflavin. And this lenticule has been fashioned from a donor lenticule. Now, the size of lenticule again is an issue which I will be discussing shortly, but right now I'm just talking about the technique. So now this lenticule is now introduced into the pocket. It is spread nicely. You check with the slit beam, and so that there's no fold, and then again you go ahead with the cross-linking. Now, initially, this is the day one picture. You can see the lenticule is quite swollen, but with time what happens is the lenticule thickness reduces and the clarity also improves. Now this is a post-op 6 months period. You can see here the lenticule margin, just you can see here, rest of the part is clear. Now a couple of issues I will talk over here is that initially we started implanting a lenticule of 7 millimeter size. So what we found out that in large cones, the peripheral part of the lenticule was coming under the cone, and that was further increasing the elevation in that area. So now we have started putting 8.5 millimeter lenticule, and the results are quite good. The second important point is that you are going to get two interfaces in this condition. Now, you have to give topical steroid on long term, just like any lamellar keratoplasty that you do, because if you don't do that, the interface haze will become permanent. So topical steroid, if you give on long term, the result is very good. The cornea is very clear, and with an 8.5 millimeter lenticule, you can see the regularity of the map of the cornea. This is what we want to achieve. So that is something which we do, and this is not basically a refractive procedure. This is basically to regularize the cornea so that the patient can be rehabilitated with contact lens, and provide tectonic support as well, so that the patient may not require the keratoplasty, or maybe keratoplasty may be deferred for years. So again, some topographic pictures. Another thing that has just recently been described is the adaptive fluence, wherein the same conventional power is used, 3 milliwatt per centimeter square. This has been reported by Farhad Hafeezi et al. And they have shown that this is a sub-400 protocol which allows for treatment of cornea as thin as 214 microns. But there's a lot of fallacy in that, because on one hand, you are talking about protection of the endothelium. The other hand, you are using in 214 microns. The second thing is that they have not documented any loss of endothelium by this procedure. They have just presented in the paper that there was no corneal decompensation. Now, these are all young individuals. Even if you have endothelial damage, they will not show any decompensation in the early period. So that is a big fallacy, and it has been used. The duration of cross-linking has been as low as 1.5 minutes. So that is something which cannot be considered. So in conclusion, the idea of doing cross-linking is to strengthen the cornea, increase tectonic strength, and there's some degree of flattening, delay keratoplasty, so that we can provide visual rehabilitation with good contact lens fitting. Just a word about oxygen supplementation. These days we are getting a lot of reports, a couple of animal studies by Theo Seller group. They showed that since by exposure of UV rays, the oxygen concentration in the stroma reduces significantly. It goes to 0. So whether if we can provide oxygen from outside, since the cross-linking requires singlet oxygen for bonding, if we provide oxygen from outside, then it may increase the efficacy of cross-linking. People are doing studies, and this is one oxygen goggle that is being used, which is quite expensive. We introduced our own, created our own goggle, indigenous design. This has been accepted in the European Journal of Ophthalmology, this unique design wherein we have opening in both this is a simple PPE goggle, wherein we create an opening of 35 millimeter on both sides. If it's being to be done in the right eye, the left eye opening is covered with a drape, and then it is connected with a tubing to the anesthesia machine to check for the oxygen supply in the region. This is the tubing that goes to the oxygen goggle. Here, this tube goes and it provides oxygen at 5 liters per minute. And the tubing at the top here, this is measuring the oxygen saturation that is there. And that oxygen saturation is seen in the anesthesia machine, which shows, with 5 liters per minute, it shows about 85 concentration, 85%. So this is something that we have tried. As far as the outcome is concerned, the cost of this goggle is just rupees 400, as opposed to the goggle that is internationally available, that is extremely expensive. What we found out that there is reduction in Kmax, but there is not such dramatic thing that more oxygen you put, there will be more and more flattening. It is not, there is no linear correlation like that. There is some increased degree of flattening of Kmax, but the result is not so dramatic. So we can still, we need to do more studies to understand whether oxygen by topical method, by increasing the periocular oxygen concentration, whether it is going to affect the outcome of cross-linking significantly. So thank you very much for your patient listening, and we can have any question or discussion.
Thank you, Dr. Rajesh. I just wanted to know, what happens when you place the lenticule intrastromally? Over a period of time, how long have you followed up? Is there a change in the pachymetry depending on thinning of the lenticule, and what do you do about it? Do you need to explant after some time?
Yeah. So the point is that we can introduce the lenticule in cases only wherein the thickness is about, say, 320 microns, because the machine doesn't allow. I introduce the lenticule at the thickness of 150 microns. We have a cap of 150 microns. So at least you need 150, 170, or 180 microns. So the minimum for the base, for the bed. So the minimum cutoff for the machine to allow to create such a pocket will be 320, 330 microns, right? I put a 200 micron lenticule in the stroma. Now this 200 micron lenticule is already a little swollen because obviously these are donor lenticules and I'm taking a stroma. So this reduces. On day one, it increases from 200 to almost 280, 290. But with further use of steroid and all these drugs, the thickness reduces, the endothelium works, there is detergescence of the stromal lenticule, it reduces. At, say the thickness reduces further down from 200 to close to 120, 130 in the periphery. I create a hyperopic lenticule, so in the center I ablate for about 70 microns. So the central thickness initially is 130. That reduces to, the 1 year follow-up has shown that reduces to 89. That's the average thickness. So even if you consider that 89 microns and somebody who's having a 330 thickness, so close to 420, 430 it goes. And if it remains like that, you have stiffened the cornea also. And if it remains like that for very long, you defer the keratoplasty for a very long period. It is just a 1 year follow-up now, so we can't, 2, 3 years follow-up now, so we cannot exactly say. But yes, till date, it has deferred. So should definitely defer the keratoplasty for maybe a decade or maybe 10, 15 years. Or somebody may not require it at all. Yeah.
When you put the lenticule by itself, it's going to strengthen the cornea somewhat.
True.
And this tissue is from another person. So it is not having the texture of the tissue which is swelling on its own because of the process of keratoconus. In that case, would it help to compare whether actually just the lenticule would also help, or would it be like cross-linking with lenticule?
See, lenticule may help. The idea is lenticule will increase the tectonic strength, increase the thickness. The idea is also to stiffen it. Right. We can stiffen the cornea. It allows us to do cross-linking in thin corneas. So both the ideas are incorporated in it. Increase the tectonic strength, increase the thickness, stiffen the cornea so that the
progression is halted.
Yeah.
So if we look at it, it's whether we are stiffening the cornea or whether we are halting the progression in terms like, so it's about halting the progression. So
absolutely.
If you add this wing to the comparison, where only the lenticule is also studied along with doing lenticule and cross-linking, maybe
actually, if you put only lenticule, study the demographic changes over the period. But stability of the cornea cannot be studied because there's no logic that why you are thinking about stability, because you haven't done anything for the stability. You have just increased the thickness. So that is the reason why we thought that we cannot comment on stability unless we do something for increasing the stability.
What is the refractive change, though? The lenticle that you're putting in is presumably from someone who's had SMILE, is that it? Or I must have missed that. So isn't there going to be a big refractive component of the lenticle? If it's like a SMILE lenticle that has been donated, in a sense, and then you're placing it, well, there's a refraction that will facilitate the change, and therefore you're looking at the tomography. That's going to be different, right?
True, I completely agree with you. That's why I said that this is not a refractive procedure. It is just to provide tectonic support. And I mean, maybe if this condition, if this procedure gets fully established, then maybe with time we can customize the lenticule and do more of a refractive correction as well with this kind of a lenticule. But at this point of time, we just have to establish that whether this technique is going to help on long term or not. That's the basic idea.
Possibly that customization will help in like having a tapered edge also, as you were saying, it was increasing the bulge with a uniform thickness.
So this was more a problem when we were using 7 millimeter lenticule, but when we were using 8.5 millimeter, it is not causing a problem because the cone, by the time you get even 7-8 millimeter cone, the thickness reduces down to even sub 300. So that's the issue. Yeah. So to reduce the initial inflammation, we give steroid for 6 times a day for a week, and then reduce it to 4 times a day for 2 months, and then reduce it to twice a day till 6 months, and then once a day for a low potency steroid we give once a day for the next 6 months. That is what we are following now, because initially we stopped steroid in some of the cases as early as 2.5 months, and then we saw that there was significant interface haze, and that is why we felt that we need to give steroid. And when we started giving long-term steroid, then the interface haze is no more, as I showed you the couple of photographs. So that's what I feel, that we should use steroid in a similar manner as we do for any lamellar procedure, initially even more than the lamellar procedure.
Component with it, and we are now titrating it or matching it with the recipient refraction. So if we are just using it as a tectonic graph, then there will be a huge change in the refraction. And if at all we are using it to correct also, then you have to do all the algorithms to correct it according to what is the requirement. So in that case, it will be like, if you are, it is not a mechanical thing, it has also got a refractive component. So the fact that just any donor lenticule will not work. You have to really go into the nitty-gritty of what was the donor's refractive power, what is the thickness of the lenticule, and moreover, we are giving steroids for a long time. So all the complications of steroids being given for 6 months or so, because traditional keratoconus, when they are doing these easier, just about 1.5 months of steroid is good enough. So is it really a very good procedure as compared to the traditional one? That is my query.
Yeah. As we were just now discussing, that this is not a refractive procedure in the current scenario, at present. At present, the idea is to increase tectonic strength and also to stiffen the cornea. Now, once we see that this procedure is well established and it's doing well, it has deferred the keratoplasty and it's working well, then obviously we have to customize the lenticule. It is actually right now a tectonic procedure to increase the strength of the cornea, to increase the thickness of the cornea, and to stiffen the cornea. That's the only thing. We can do cross-linking in thin corneas, and we can increase the tectonic strength as well in these corneas. That's the basic idea. The visual rehabilitation has to be done by use of contact lenses.
I have a small question. This lenticule and everything is not available, and femto is also not available generally, increases the cost. What are the cheaper alternatives? Like how thin can we go in with say a HPMC riboflavin, or how thin can we go with a hypotonic riboflavin?
Sir, actually,
are there, like, have you clinically seen, like in very thin corneas, if you do a hypotonic or say a HPMC corneas that are 350 or less, do you land up with actually a clinical decompensation?
Actually, in hypotonic, if you consider the hypotonic cross-linking, then up to 330 microns of thickness of cornea has been swelled up to 400, and cross-linking has been done with reasonable success, with whatever success that we get in hypo. As far as the, you asked something about, lenticule availability or femto availability. Sir,
No,
actually...
see, I don't want to discuss the femto at all.
Yeah.
Just with the non-femto, non-lenticules, because that's not available everywhere.
Yeah, that is fine. So up to 330 microns, one can do hypo CXL, and hypo CXL also has some effect. Definitely not as comparable to conventional cross-linking, but it does have some effect, and yes, it is being done.
Do you think a multi-layered AMG would allow penetration of, because AMG is more easily available, penetration of the UV light? Because even the BCL also are very difficult to get.
Sir, anything if you put on the cornea, it is doubtful that the penetration of the UV light will remain the same. And the idea is that the cross-linking works mostly in anterior two-thirds of cornea. If you put a multi-layered amniotic membrane, which you will discard later, obviously the outcome may not be the same as conventional. You cannot compare that.
Okay, thank you. So there are no actually solutions for very thin corneas.
Sorry?
Doing on thin corneas is still a challenge right now.
If in a thin cornea, instead of, I would say, hypo CXL still has a role. It does have some effect, definitely.
Thank you.
Just to answer Samrat's question on
I have
doing the procedure, you can do the same lenticule, preparing the lenticule with a microkeratome. So you can prepare a anterior 130 micron or 200 micron using the microkeratome, which also gives you a shape which is slightly thicker in the periphery and thinner in the center, because that's how the flap thickness can be. And the pocket can be created manually using lamellar dissector. So if you really wanted to do a stromal augmentation, you can do it without the use of laser. Second thing, in some part of the discussion, the refractive outcome of stromal augmentation is not predictable at all, especially in eyes with keratoconus. So we should not translate what we see in refractive procedure in SMILE, where you have a normal cornea and you have control over what you are removing and what change you are creating. In keratoconus, when you put in a lenticule, you theoretically in your mind you think that yes, I am putting it, I should get this refractive change, but doesn't happen. But what it basically does is it helps centralize the cone. So the cone that's down, you find that the cone is lifted up, more central. So it can help reduce the hyoid aberration, but the patient still requires to use maybe a contact lens where he still has to use glasses. And the visual improvement can take several months, even up to 6 months for the patient to perceive. You will not get that immediate improvement. Once you put the lenticule, the vision will drop, and that edema to settle down, it takes at least 4 to 6 weeks. All these needs to be discussed with the patient.
Dr.
Thanks,
Rajesh,
Rajesh.
even if you create a lenticule with a keratome, how are you going to create the femto pocket in the host eye?
You can do a lamellar dissector, just like what you use in DSEC. You can make a peripheral groove and then use the lamellar dissector to decrease. That's how Melis group is doing the Bowman's layer transplant. They are not using a femtosecond laser. They are manually creating the pocket within the stroma, and they are introducing the Bowman's layer. So if that works, then this should work.
Would that lead to more haze because of the cross
Maybe
lamellar?
not. I don't have the experience for that, but I think a lamellar pocket can be created. Even when you do it at varying depth using the femtosecond laser, because of the shape of the cornea, you don't get a flat pocket. You do get, because when the cornea is applanated, you do get a little corrugated kind of interface. So it's not like a flat interface that you see in the OCT as well. Depending on the depth at where you place the lenticule, also it induces change in the anterior surface. Place it too deep, see the changes are more in the posterior curvature than the anterior. But if you place it too anterior, maybe you will get a change, but then the epithelial healing sometimes takes away that change that's been introduced. So it's still a very variable thing where we don't have, but I think maybe we'll go there, we'll reach there as more and
There is one more question, Dr. Sinha.
Yeah.
See, if we are putting a lenticule in the stroma in the cornea, which is about 400 micron thickness or 360 micron or 370 micron, then theoretically, if we are putting a 150 micron lenticule inside the cornea, it should just be adequate to ensure the proper normal thickness of the cornea. So I don't think it would need to lot of refractive change, what people are saying about. I just want your clarification on this.
Actually, sir, the point is that this procedure is not a refractive procedure. The idea is to increase the tectonic strength of the cornea. stiffen the cornea so that we can manage the patient with the patient, the requirement of keratoplasty is deferred. That's the basic idea.
Thank you very much, Dr. Rajesh. We'd move on to our keynote presentation for this session, which is by Dr. Audrey Rostov. She's the Director of Cornea, Cataract and Refractive Surgery at Northwest Eye Surgeons in Seattle. She is a presenter of various international fora. She conducts the Refractive Surgery Day at the Ascaris, and she has toured India widely. And I think just as her presentations are very informative, she carries the Indian attire also with a lot of grace. On to Dr. Audrey. Her topic would be cross-linking complications.
Great. Thank you so much. It's wonderful to be here and to see everybody in person. These are my financial disclosures. I am a consultant with Glaukos that does make a cross-linking device. As we know, there's epi-on and epi-off cross-linking in the US, which is where I am based. We have our FDA is approved for epi-off. I have been involved with clinical trials for both epi-on as well as epi-off. The complications of cross-linking are, of course, well known to us, and I'm going to go through these and discuss some treatment. Infectious keratitis is probably the most common cross-linking complication, and of course it comes in the usual varieties with the usual suspects. This is a patient who had staph coag positive bacterial keratitis. This was a patient of mine treated with fortified vancomycin, and this resolved nicely in a few weeks. The nice thing, in a sense, if there is bacterial keratitis and it's successfully treated, is you often get more flattening of the cornea, so that can be an unexpected bonus. Alpha strep keratitis is another fairly common etiology for bacterial infection. Hsv keratitis, early on when I was in the epi-on cross-linking trial, I actually had a patient that I had, as you can see here, had intrastromal corneal ring segments and developed bilateral Hsv keratitis following epi-on cross-linking, treated with oral valacyclovir and topical ganciclovir, and this resolved in a little over a week. Again, there was more flattening. With HSV infection, of course, can occur after cross-linking. It makes sense. It's UV light. There have only been a few cases actually reported in the literature. If someone has a history of active oral HSV or frequent oral HSV and or atopic disease, I would consider prophylaxis with PO antivirals. Prompt treatment, again, and prompt recognition can lead to good outcomes. Acanthamoeba, of course, has also been a dreaded complication, just like any sort of epidefect. My experience at my center, and I've done about over 1,200 cases to date, epi-on was only about 300 or so, and then I've had about 1,000 plus of epi-off. I had 3 eyes of 2 patients, the one bilateral HSV that I mentioned, also a staph coag negative. Both patients resolved their infections without loss of best-corrected vision. For epi-off, I've had 8 eyes of 7 patients. What's interesting is that I saw a slight uptick once COVID hit, and I believe it was from mask wear. I think that if you look at the patients who come in and you see what their mask looks like, they really need some education about frequent changing of disposable masks and also washing of the non-disposable masks. In the literature, of course, infectious keratitis following cross-linking has been well described. Again, all the usual suspects and all varieties. Infection prevention, again, with HSV patients, oral and or ocular, consider PO antiviral prophylaxis. Caution in atopic disease because of potential both for HSV as well as bacterial superinfection in patients with bad atopic disease. And I actually put on a bandage lens and see the patient every 24 to 48 hours, including frequent changing of the bandage lens, again, to prevent infection. Perforation has also been described. There was a series of brittle cornea disease, that there was perforation. Perforation has also been described in the literature due to microbial keratitis as well. So this has been a hot topic that has just been discussed with the last paper. What about corneal pachymetry under 400 microns? This has not been associated with perforation or endothelial harm. For at least the Glaukos device, it is approved for corneal thickness greater than 400, and as we discussed, you can use hypotonic riboflavin to swell the cornea. That works quite well. There is in the literature, cross-linking has been performed for 300 to 400 microns using the hypotonic riboflavin and has not ended in endothelial damage. Delayed epithelial healing due to dry eye disease can also occur in epi-off cross-linking. If you have a patient who has dry eye disease, and of course they can get an increase in dry eye following, you want to really be careful. Make sure that you are lubricating the eye a lot, and this could take just the usual, artificial tears. You may need to use ointments, patching, even amniotic membrane. I use amniotic membrane actually to help resolve these defects if the usual things don't work. I've also used Synergimin, that's by the Italian company Dompe. They have it's approved for neurotrophic keratitis, and they have the nerve growth factor, and nerve growth factor can also be helpful in very stubborn cases. Corneal haze, another complication. This can occur just on its own. We all see a little bit of that. I call it healing haze following cross-linking, which we're all used to seeing, the healing haze, and that usually goes away by about a year. Most cases don't affect vision. There have been some cases, though, of late haze, almost like a central toxic keratopathy that you can see with PRK or LASIK on occasion. I've actually seen this in a couple of patients who had post-LASIK ectasia, and then a few months later developed significant corneal haze. The important thing, if they do have significant haze, is essentially to treat them with topical steroids very, very aggressively. And with prompt treatment of topical steroids, you can get a very, very nice response. It can take several months of steroid treatment, however, but I would say to be aggressive. I've even used a short course of oral steroids as well in one patient. I believe she had some kind of traumatic event a few months later, sort of like we would see with the DLK kind of look to it as well. Again, haze prevention. Basically, prevention is sometimes your best cure. Prevent and avoid delays in epithelial healing by treating dry eye disease aggressively, and again, aggressive topical steroids. What about progression? Risk factors for progression, of course, include young age, eye rubbing, high preoperative Ks. Progression rates in general, I quote, about 3 to 7%. I tell patients when they come to see me that they have a 90 to 95% chance of having just one cross-linking procedure, and there is a 5 to 10% chance of progression. This was a patient of mine, a 15-year-old who came to see me with Keratoconus, and so as we heard from the first talk, when to treat. Unfortunately, this patient did not come back, and then over the subsequent 2 years when they were seen, really ended up with significant progression. I really like looking at difference maps rather than just a K-max. Sometimes you can see a steepening and you don't know if it's epithelial remodeling or if it's real. You have to look at epithelial maps as well, but I really like the difference maps because you can see more of what's going on in the cornea. Of course, always, always, always ask about eye rubbing, and then dive a little deeper into why they rub their eyes. Is it because of allergies? Do they need treatment? Is it dry eyes? Is it habit? Really inquiring as to a deeper dive as to why they rub their eyes can really help your patient as they try to eliminate that behavior. A last issue is epithelial ingrowth. I've seen this several times with patients with history of LASIK and post-LASIK ectasia. You have to be careful when you are removing the epithelium in epi-off cases because you can still lift a flap edge, especially of a microkeratome flap years later. We all know that there's cases of trauma following following LASIK years and years later, and it is traumatic, of course, to do the surface removal of epithelium, so you can get, in fact, epi-ingrowth. These were two cases. You can see that right at the edge there was some significant epi-ingrowth. So what to do? Well, if it's just peripheral and there's a demarcation line, you can just observe and you don't have to be that aggressive and lift flaps and treat. I find these flaps can kind of be rather more difficult to lift, as well as issues with being able to get the flap to lay down properly and to prevent recurrence of ingrowth. I've done YAG treatments with a YAG laser for epi-ingrowth, and I find that that works really quite well as being minimally invasive. I start with a millijoule and I increase as needed. You basically YAG all the cells until you see them clear, and also this can take several treatments. So in summary, educate your patients to avoid dusty, dirty environments, good hand washing, and in this COVID age, of course, change masks frequently. Treat haze aggressively using post-op steroids. Treat dry eye disease. Sometimes the best treatment is prevention with lubrication, anti-inflammatory meds, some topical steroids, punctal plugs, amniotic membrane if that's necessary. And if you do get epi-ingrowth, you want to watch this, especially for patients with a history of previous LASIK. It can result in some scarring. Thank you so much.
Thank you, Dr. Rostov. It was really very educative, and I mean, many of these complications we have seen, and very nicely presented the management options for all these. Please take a seat. We will have, we have a question here.
Good morning.
Yeah.
Ma'am, please. What is the percentage of your cases with posterior lenticonus, keratoconus only been treated for C3?
Sorry,
how frequently do you treat posterior keratoconus only, and there is no anterior signs or topography negative thing?
I'd say it's a relatively smaller percentage. You know, it really depends on why you are treating, right? And so if it's a young patient, you know, treat fairly early because you know they're going to progress. If it's an older patient and really you're just seeing some posterior signs, I pay close attention to the epithelial map because as we know, the first signs of keratoconus actually occur anterior. And so if you're seeing the anterior changes in the epithelial map, then I would be more likely to treat and more aggressive. If it's isolated, just posterior changes and not much is happening, then I'm not too excited about it. And so I'd say a relatively smaller percentage for treatment there.
Do you wait for some progression or those cases?
I would say it just depends. So it depends on what the goals are. It depends. I don't think you have to wait for progression. I don't necessarily absolutely wait for progression. I see what the goals are. You know, if they're able to have good best corrected vision, then I don't think there's any rush to treat. If, however, it's an issue and you want to get the patient back into a contact lens or something like that, then I think it's certainly reasonable to treat. I've also done a number of cases where I've done cross-linking and then I do topo-guided PRK as a refractive procedure to help them get better best corrected vision, not to be glasses independent or spectacle or contact lens independent. It's to actually help them be able to achieve good best spectacle or contact lens corrected vision.
Thank you. Thank you. Now we move on to the next talk, and that is on intracorneal ring segment in keratoconus.
One question, please.
Okay, yeah.
Can I go ahead? My question is individualizing the Fluence for cornea is thinner than 400 microns while doing cross-linking. See, you can go even up to 250 microns. Any experience from the people on the diet?
Sorry, I think cornea is less than. So, sir, can you just repeat your question again?
Individualized fluence therapy, that means you monitor the fluence according to thickness of the cornea.
Okay.
Yeah, actually there's a study recently published by Farhad Hafizi group regarding the adaptive fluence. That's what you were asking, sir?
Yeah.
Yeah. So they have shown that, even up to 214 microns of thickness of cornea can be treated by, reducing the time period of exposure to UV rays. They have shown up to 2 minutes time of exposure to UV rays, it can be cross-linked. I mean, but they haven't studied the endothelium at all. They have just shown that there was no case of endothelial decompensation. But what was the endothelial cell loss, etc., that is not there in that paper. And that is how, I mean, these cross-linking are done in all young individuals. And there may be endothelial damage as well without causing decompensation, significant decompensation. So, I mean, that is a big fallacy in that. And maybe, I don't know how much we can be sure about the efficacy and safety of that procedure. Maybe with time we will be able to know. Any other comment?
Feel it is advised we should go through it, or as it is mentioned in the literature with good result.
Sorry?
No, sir is asking if it has been mentioned in the literature. I think it is a published study.
It is a published,
Yeah,
it is published in American Journal of Ophthalmology by Farhad Hafizi group.
Unfortunately, that software or whatever they use, they only have it. Nobody else has, corroborated on it. And I think future studies would be required to know how much it works and whether it does compromise the endothelium or not.
Thank you.
Okay. Dr. Sapna, please.
Thank you, Dr. Rajesh, for having me here. So I'll be steering away from collagen cross-linking for a moment. We'll be going into not only a tectonic but also refractive process for keratoconus, to deal with keratoconus. So as you know, in a very simplified way, myopic correction by LASIK is by taking off central tissue from the cornea, whereas in ICRS we add tissue to the corneal periphery. Now, there's some principles on which intracorneal ring segments are based. Basically, the arc of the segment, then the thickness of the segment, and the distance from the center where it's placed. So all these modify the refractive correction provided by the intracorneal ring segment by way of flattening the cornea. So that is how various companies manufacture their segments, and that is how, those are the criteria we use to insert the segments into the cornea. Now, when do you think about inserting corneal segments? Are when there is loss of vision due to keratoconus. So it can also be done in a patient with good vision, but with a very high refractive error, a very irregular cornea. So most such people do not have a corrected distance visual acuity of 6/6, so that is why the loss of lines comes into significance. Where the corneal dioptric value is more than 46 diopters, the central cornea is clear, so we're not talking about high drops or a pacified cornea. And then you need to have a minimal pachymetry of 450 microns at the region where you plan to insert the ring. So again, here we're not talking about the central pachymetry, but the mid-peripheral. Now, the conditions which are amenable to treatment by the intracorneal ring segments are not only keratoconus, but also in LASIK ectasia, after penetrating keratoplasty when the astigmatism is too great, post-traumatic patients, post-RK patients, and in post-traumatic patients without any central corneal scarring, and also in PMD where you need to place asymmetric ring segments. When do you not place those ring segments? When you're dealing, as I said, with corneal opacities or dystrophies, endothelial or stromal. When you have recurrent corneal epithelial erosions in patients with dystrophies or in patients with a lot of eye rubbing, in autoimmune disorders where you're not sure about the type of healing or the extent of scarring that may happen, unstable conditions like pregnancy, and in some drug intake where the cornea is also affected. You have to be cautious, like I mentioned, in patients with vernal keratoconjunctivitis, low endothelial cell counts, and large pupils, just to make sure that your segments don't come in the pupillary interface. Now, what are the types of ICRs we usually deal with? Of course, there's intacts, there are Ferrara rings, there's something called a Mayo ring, and all these follow the basic principles, but they have slight differences between them depending on the type of cross-section, the arc segments that are produced, and the distances from which they are kept. So coming on to intacts, which is what I am most familiar with. So it has an arc of approximately 150 degrees. It's hexagonal in cross-section. It has an internal diameter of 6.77, which in a steep ring turns to 6, and an external diameter of 8.1, which for a steep cornea can be reduced to 7.3 as it brings about greater correction. Thickness varies between 0.21 to 0.5 millimeters. The Ferrara are yellow PMMA rings with multiple shapes of arc. They have a triangular cross section and the height varies. So you have a 600 micron base, 800 microns also available, and the thickness depends on the height of the segment. So as you can see over there, as the pyramid height increases, you say that the thickness of the segment has increased. The Kera ring is very similar to the Ferrara, only thing you have a wider number of arcs and smaller optic zones. A Mayo ring is a complete ring, and it is a continuous ring which varies in diameter from 5 to 8 millimeters, and it has a 0.2 to 0.3 millimeter thickness. It has an upper convex and a lower flat surface. Now, this is a manual incision of a corneal ring segment. After centering the mark on the cornea and marking the area where the incision has to be made, the main incision is opened up, along with passing of the keratome used for the, it's a spiral keratome which is used to construct the channel for the ring. So as you can see, this is the manual method of doing the same procedure. The same procedure with the femtosecond is very much faster, much more accurate, and much more enhanced. So this sometimes leads to channels that may be slightly superficial or too deep, and that is why there used to be more complications when only manual techniques were used, such as extrusion of the ring either into the anterior segment or up onto the epithelium. So once channels are made, the rings are passed. And now here, this is a Mayo ring, and this is passed into a lamella section like you saw the passage of the lenticule, and that goes into the interface, and it sits centering on the pupil. So it produces a uniform addition of tissue to the entire periphery of the cornea. There you can see that it's centered, and now here to the intracorneal ring segment. Again, this is done using the femtosecond laser. The marked. Following this is the operation that is used for creation of segment pockets through which the rings are inserted. So once applanation is completed, you can see that the femtosecond laser takes place in the blink of an eye. So it is that fast, the creation of the segments, the small tunnels, and the incision as well. Now once that is made, all that is required is opening of the main incision and then making the channels patent using the ring itself. So this dissector is usually initially used to expand the tunnels and also create the initial channel to dig into the plane and discover the plane of the segment. The rest of the dissection is done using the segment itself. So that is the ring segment. So here, this has a hexagonal surface, and it's used to pass. So you can pass one segment or two segments depending on what kind of refractive error you're treating, astigmatism or large amount of myopia, and the ends of the incision or suture using 10 or nylon. So if you have large central myopic cone, you use symmetric segments. When you have a high astigmatic component, asymmetric segments, and in oval cones, you can use a single inferior segment. The mid-peripheral pachy, as I mentioned earlier, is more important. Even if the central pachy is lower, as you can see in these cases, if the mid-peripheral pachy is quite good, like in the first one, then that 450 is the cutoff for that. So you can see that there is a lot of correction of myopia in such cases. -10 diopters has been corrected in this patient. There's some amount of residual astigmatism. This brings about a lot of change in the irregular astigmatism. Yeah, this is one of my last slides. You can see how the ring sits in the posterior part of the cornea, basically because the lamellae are not as thick as the anterior one. Now, complications include, as I mentioned earlier, protrusion of the segment either anteriorly or posteriorly. There can be too superficial implantation, can have some sort of pacification in the tunnels or infection of the tunnels. There can be persistent corneal edema on the segments. And most of the studies have reported such complications mainly with the use of the manual microkeratome. And of course, Intacs can be used in combination with other adjuvant technologies like ICL, CXL, and excimer laser. Thank you.
Thank you, Dr. Swapna, for telling us all about the intracorneal ring segment in keratoconus. I'd like to invite Dr. Namrata Sharma, who will be talking about types of riboflavin that we use in various methods of doing cross-linking. So let's hear from her.
So thank you, Dr. Rajesh, for making me a part of this very interesting instruction course on keratoconus. I would be talking to you about types of riboflavin and the current status of accelerated cross-linking. I'm sure this has already been dwelled upon, that the cross-linking does strengthen the cornea because of the way it works, and it also increases the biomechanical resistance of the cornea. Riboflavin is a photoactivated chromophore with absorption peak at 370 nanometers, large hydrophilic molecule, inadequate to penetrate an intact corneal epithelium. And that is why you require corneal deepithelialization. And it is a non-toxic agent, and it is also a photosensitizer. I think this mechanism has already been discussed on how it works. Now, as far as US FDA approved solutions are concerned, there were two of them. Which were initially approved. One was riboflavin in 20% dextran solution, and the other one was riboflavin phosphate solution for corneas which are less than 400 microns. And if you look at the available riboflavin solutions in the market, these are the following. So riboflavin with dextran is 0.1% riboflavin with dextran. Then you have a hypo or smaller riboflavin which doesn't have dextran. Then you have riboflavin for transepithelial collagen cross-linking, and then you have riboflavin with HPMC, and then you have even higher concentration of riboflavin for extra procedures, which increases to 0.22 to 0.25%. So essentially these are two types, dextran based and HPMC based, and what we need to know is that osmotic effect of dextran reduces the corneal thickness. And the HPMC based, there will not be any corneal thinning present. It increases the diffusion rate, and there is also reduced loading time. Now, this was a study which looked at dextran versus HPMC based solution, and the difference between the two was that the 20% dextran caused more thinning as compared to the HPMC, and so the treatment also was at a greater depth when the cornea became thinner with 20% dextran. And so as a result, the demarcation line also shifted more posteriorly as compared to the one where HPMC was used. At our center, we are using this with no these are the two types of riboflavin we use with no financial interest or proprietary interest in any one of them. Isosmolar riboflavin, which is 0.1% riboflavin with 20% dextran, is the one which we have. And for hypoosmolar riboflavin, this is constituted in physiological salt saline, salt solution, and this is meant for thinner corneas. Now, transepithelial riboflavin will not penetrate in intact epithelium, so several agents have been used like BAC, EDTA, vitamin E, TPGS, and some people also used iontophoresis for the same. Even oral riboflavin has been tried by people, but there are increasing side effects of systemic side effects such as risk of sunburn and photoaging of the skin. Now, I'm sure Dresden Protocol has already been discussed, the classical Dresden Protocol. The accelerated protocol, there are various ways by which this can be done by using various energies for a varying time period. And the essential part is that the energy remains 5.4 joules per centimeter square. So you can either use 9 milliwatt for 10 minutes, or you can use 18 milliwatts for 5 minutes. And this is as per the Bunsen-Roscoe law of reciprocity. Now, there is a need for rapid protocols because the standard protocol is time consuming. It is more comfortable if you do it rapidly. And excessive dehydration and corneal thinning, which follows following 30 minutes of UVA treatment, is more as compared to when you don't use as compared to when you don't use these standard protocols. Ex vivo experiments have shown that whether you do conventional cross-linking or accelerated cross-linking, the biomechanical properties are going to be similar. The advantage is that there's reduced exposure time, improved patient comfort, and lesser risk of infection. Now, this was a study which looked at standard versus accelerated cross-linking, a retrospective study, and like I discussed earlier, the treatment demarcation line was more with the standard protocol as compared to accelerated one, and demarcation line is more superficial with the accelerated one as compared to the standard one. This is a meta-analysis of 1,158 eyes, and again it concluded that consideration of less corneal thinning favors the accelerated collagen cross-linking, whereas the deeper demarcation line and greater changes in the minimum keratometric values in conventional cross-linking may indicate a higher treatment efficacy. And although there is a difference in the way they work, but as far as the strengthening of the corneal tissues there is concerned, both of them are equivalent. Now, this was again a 5-year result of epi-off versus standard versus accelerated collagen cross-linking, which did not show any difference in terms of mean depth of corneal strobal demarcation line between the two procedures, and even the Kmax and the UCVA and the BCVA were comparable. In pediatric cases also, it has been shown that accelerated collagen cross-linking offers stable keratometry and corneal thickness up to 36 months of follow-up. Now, as far as the accelerated collagen cross-linking protocols are concerned, could be pulsed versus continuous, normal fluence versus high fluence, pachymetry-based accelerated collagen cross-linking, photorefractive intrastromal cross-linking, and LASIK extra procedures. So when you do high fluence accelerated collagen cross-linking, there will be minimal changes in the thinnest preoperative areas, and it reduces the thickness variability among the central 6 millimeters. This is as shown here. And this was a study which looked at pulsed versus continuous light accelerated collagen cross-linking, and concluded that pulsed light allows optimized intraoperative oxygen availability, which is a critical issue, and so it improves the postoperative functional outcomes because you're not cross-linking for the entire period, and the oxygen is available in the period when you're not cross-linking. And this also looked at the confocal microscopy study, and this was also confirmed that deeper apoptosis and demarcation line formation occurs with the pulsed cross-linking compared to the conventional cross-linking. Then pachymetry-based accelerated cross-linking, something that we were discussing, is now going to be the future, which is going to determine the cross-linking parameters depending upon the patient's pachymetry. And then, of course, you have the photorefractive intrastromal cross-linking, which is also done by accelerated protocol, but it is done for myopia. And then you do have LASIK extra, where LASIK and accelerated collagen cross-linking is done simultaneously for better refractive and keratometry stability. Now, these are essentially the summary of the studies of accelerated collagen cross-linking available in literature, and some of them, they say the results are equivalent, and some of them, they say that the results are better with the conventional cross-linking. Now, the concerns for accelerated cross-linking are that the biomechanical effect of the cross-linking is oxygen dependent, and that is something that needs to be looked at. And we really don't know the biomechanically, there are not very many studies which have compared the biomechanics of conventional versus accelerated cross-linking in prospective randomized controlled studies. Now, this is just to show that high fluence accelerated epithelium of cross-linking protocol in this study provided Dresden Protocol like corneal strengthening. So they concluded that it really doesn't matter even if you do accelerated collagen cross-linking with the high fluence, the results are similar to conventional cross-linking. There is variability in terms of progression criteria used, grading methods for severity assessment, riboflavin solution used, soaking time used, UV radiation used, and follow-up duration in the literature which is available currently. And I think more robust data and more well-planned studies are still required to actually know whether accelerated collagen cross-linking is equivalent or is non-inferior to true conventional cross-linking. So to conclude, by our experience and by the literature which is available, accelerated collagen cross-linking allows corneal stiffening in cases of progressive keratoconus, and variable results are reported in different studies in terms of functional outcome and corneal strengthening. The accelerated collagen cross-linking with 9 minutes and 18 millivolts in one study does show that it is similar to the standard cross-linking in experimental studies, but we do need to corroborate this further with the long-term studies and more robust trials. So we do recommend that these studies are required, and more so in the multicentric studies should be taken up with the standard parameters in these studies which should be used. And also I think the high-risk group, the young children in the syndromic association, should be evaluated separately from the general population studies. So thank you very much for your kind attention.
Thank you, Dr. Namrata, for an excellent presentation and for covering the topic very well. Now I'll request Dr. Arun Jain to speak on on a topic which is related to the visual rehabilitation, and that is whether contact lens is the mainstay for visual rehabilitation in cases of keratoconus.
So thank you, Professor Rajesh, for the invitation. So I'm going to speak is contact lenses the mainstay of treatment for visual rehabilitation in keratoconus. And the various contact lens used in the optical correction of patients. As we all know, we have heard various modes of optical correction or C3R, whether patient is pre-op or patient has some form of C3R done or some keratoplasty or lumbar procedure done. All of them need some form of optical correction, and almost 80% of the patients of keratoconus needs contact lens in some form or the other. Way back in 1998, Clegg study showed that almost 65 to 75% of the patient of keratoconus needs contact lens, especially rigid gas permeable lenses, and only around 10 to 20% of the patient will require some form of surgical intervention. Of late, this figure has also further reduced to around 10 to 15%. So most of the patients fitted with contact lens are having a vision when it cannot be improved beyond 20/30 with the glasses. And there are various options of different types of contact lenses in these patients. In mild keratoconus, where the K readings are flatter than 45 or maybe there's mild keratoconus. We have option of these soft toric lenses or hybrid lenses, conventional RGPs, piggyback or Rosca2 lenses, and moderate cases where the K readings are 45 to 52. We have Rosca2 or hybrid lenses, and in advanced keratoconus, we have option of scleral or the Rosca2 lenses. And depending upon the type of cone we have, whether it's a nipple, oval, or a globus cone, we have to choose the contact lens accordingly, because if the cone is too large or a globus cone, it will typically warrant a design with the larger diameter. And diameter of the contact lens is based on the location of the cone, its size and steepness. And coming to the soft toric, they are only helpful in early keratoconus cases, but they are quite easy to handle and they give good comfort to the patient. But the cones, the downside is they correct only low amount of cylindrical power and vision is compromised. So the indications for these soft toric lens are only early keratoconus or where RGPs are not tolerated, and as they fail to mask the corneal astigmatism. The Kerasoft is another type of soft contact lens which are available in conventional hydrogel or silicone hydrogel lenses. They have relatively flat base curve and they also neutralize the aberrations to some extent, and the special design to drape over the cornea instead of masking the irregularity of the cornea which is the usual mechanism of Rosca2 lenses, is the basis of this lens, and they are good, have a very good comfort, and they are simple in handling and highly customizable, and they can be used in mild to moderate keratoconus. But the downside is vision is not that crisp as they are comfortable, but it cannot be used in advanced cases of keratoconus. We have this publication from our center where we compared Rosca2 with the Kerasoft lenses, and we found that though Kerasoft lenses were comfortable, the vision was better in Rosca lenses in terms of contrast sensitivity. So Kerasoft lenses can be considered as a good alternative for optical correction of corneal astigmatism in patients with keratoconus who don't tolerate RGP lenses. Then coming to the RGP lenses, which are the mainstay of optical correction in cases of keratoconus, and they are made of their decay value is very high, they are quite affordable for the patient, and very crisp vision is there and can be used in mild to moderate keratoconus, and though initially there is a low comfortability, but as the patient uses it, they become more and more tolerable, and they are also suitable for high cylinder and irregular cornea. The Rosca design is different from the traditional RGP design. It's a tri-curve design, so it drapes around so you can see in normal lenses they have a pool around the cone, but the Rosca tri-curve lenses, they conforms to the cone of the lens, so that there is no pulling of the tears and the oxygenation of the cornea is not affected. And in further designing of the lens, Rosca2 lenses, they are aspheric as well as their optical zone is larger, so the quality of vision and the field of vision is much larger. And I won't go into details of fitting method, but the most important is there are 3 different fitting philosophies, either apical bearing, apical clearance, or 3-point touch, and the 3-point touch is the most widely accepted one. So once you fit in a contact lens, you should be looking for a gentle touch in the center, mid-peripheral bearing, and there should be an adequate zone of 0.75 to 1 millimeter edge elevation, and the lens should be assessed in a dynamic form immediately. You have to wait for half an hour, and immediately after blink you can see there is a very feather touch in the center, and if you wait for some more time there will be less and less of pulling as the dye clears up, and there should be appropriate edge lift so that the exchange of tears happens. And as you can know, if there is too much of apical bearing, it will lead to scarring, and if there is too much of steepening, it will affect the oxygenation of the cornea. And there is one representative patient with Hsv Keratitis. The patient came to us from outside. He was already using these lenses, as you can see, because these lenses are too flat, and it has led to a apical scarring in both the eye. So we changed the lenses and and these are decentered also. There are inferior shift of the lenses in both the eye. So fit has to be proper so that the quality of vision is not fluctuating, and you should avoid any apical bearing or too tight lens. This is a publication we did way back in 2006, and we showed that almost 100% patient with moderate keratoconus can be fitted with those K2 lenses, and almost 90% of the patients of Hsv Keratoconus can be fitted with those K2 lenses, and chair time is much less, and only 1 to 2 fits are required to do this. Coming to the scleral lenses, as we all know, these are defined as a lens fitted to vault over the entire cornea, including the limbus, and to land on the conjunctiva overlying the sclera. So the advantage of these lenses is they have a good comfort, lens stability is there, they are highly customizable and correct advanced cases of keratoconus. But for patient, the lens handling is little difficult, but they learn it over a time, and they are also very expensive and ideal for the intolerant rigid lens wearer, regardless of the stage of the disease, and they may delay or avoid the need of surgery. So what is the lens anatomy? It has a central clearance zone, and there should be a clearance of around 150 to 250 micron in the central area, and the mid-peripheral zone is limbal independent transfer zone, and it should be around 50 to 100 micron. So the clear space gradually taper to the periphery, and the scleral landing zone is an angle that aligns on the sclera and bearing the sclera bearing sector of the lens. And based on the size of the lens, they can be classified into corneoscleral, semiscleral, miniscleral, and full scleral lenses. And this is how you access. After putting a lens, wait for adequate time and see the clearance between the two. The guidance is compared to the thickness of the lens or thickness of the cornea, or if you have, and these are the fitting parameter. The 50-50 rule is applied. There should not be too much of impingement or too much of elevation of the lens edge. There should be 50-50. This is the good alignment. This is edge elevation, and this is impingement. This is the ideal fit, and this is one represented patient with Hsv Keratoconus. And this is if you have OCT, one can use OCT for this. You can see the clearance between the lens and the cornea is 235 micron. This is the right eye. If you think this is too high, you can fit another lens, and this is the adequate wall. Just 1 or 2 slide. And this is the left eye of the patient with 300 volts, so it needs to be around 150 to 200. And this is the both eyes of the patient fitted with the scleral lenses. And this is post keratoplasty. You can see the adequate clearance of this lens. So coming to the final conclusion, so we can divide keratoconus into different stages, and depending upon the stage, you have different options of treatment. But whatever treatment you give, you need some form of optical correction, be it spectacle or contact lenses. So contact lenses alone or in combination with different procedure are the mainstay of optical correction of keratoconus patients. Thank you so much.
Thank you, sir, for a nice presentation. And now the last thing that we have to know is when should keratoplasty be done, and Dr. Jagruti Jadeja will tell us.
A relevant course on a very happening subject. Queries based, so the last query, as we said, is when keratoplasty is to be done. Keratoconus by itself, the progressive thinning and bulging induces the distortion in the cornea, leading to the blur, as can be seen here, with no proper focusing, and cannot be fully corrected by any optical correction. In advanced cases, there is a loss of vision, and majority of these might end up having surgeries, and we would want to define when would the surgeries be applicable. But there is no precise definition to say absolute cutoff for those advanced cases, despite all the indices, metrics, the ASOCT and topography features which will help you in sort of grading them, because there's a very poor correlation between this indices and the actual clinical effect of that distortion. A very mild case might still have a lot of distortion, whereas a very advanced case might still be correctable with the other means. So when surgery, when the high irregular astigmatism or the scarring primarily because of the disease process or secondary to hydrops leads to a functional loss of vision, where the correction is inadequate or not tolerable in terms of the lenses that we talked about, and the visual excess is not spared. So if the visual excess is obscured like that, or there is a very advanced thinning with improbable fitting of a good correction, that's when, and when the other means of halting the disease progression have exhausted, or the patient primarily presents where these means are no longer applicable, or there are complications from the earlier discussed means. So all this, the final go would be correction with keratoplasty, or if there is a corneal infection due to the contact lens wear, and that is now rendered with an opacity. There are charts, flow charts for those of us who prefer to have a discretion over like when to actually step into this. With all this cross-linking, the trans-PRK with cross-linking, the ring segments and combinations of all this, finally, when none of this is like applicable is when you are going for transplants. Transplants by choice for those conservative people who don't choose to go beyond the safe limits of the earlier discussed modalities. That's when you don't want to actually risk the probable ill effects to the stem cells or the recently discussed sudden absorption of the corneal stromas, which have been being discussed on the cornea groups, where you find this cornea to have reduced to 150 or 200 microns post some years of cross-linking. Surgery, classically, a penetrating keratoplasty has excellent outcomes visually, optically, where we have a full thickness disc which is placed there and secured in place with sutures. Yet, over the years, DALK has become the chosen or the golden standard for this type of conditions, advanced keratoconus, where you dissect as deep as possible, leaving the healthy endothelium in place, and place the donor button shelled off of the endothelium and suture it in place. Now, both these techniques have sutures in place, yet DALK does not have an open sky. It's in stronger eye in the long term. Little work is done in the anterior chamber. No risk of endothelial rejection, which decreases the need of further replacements. There is less requirement for steroids, less risk of secondary glaucoma, and this can be further fine-tuned with the use of femtolaser if available. Now, this is subject to endothelial health and scarring. If these two were present, then you are not having a chance of doing a DALK, though in some cases of scarring, you might still be able to manage to a DALK. The procedure for DALK would be either a manual dissection or the big bubble technique, and the big bubble technique can be type 1 or type 2 with reference to the Duval's layer, where the dissection will be in front of it or in. But then there's more to this when about surgery. Classically, this is what we would talk in terms of the optical things. But then if you look at these eyes, which are often having the vernal keratoconjunctivitis or the allergic conjunctivitis factors, or in dry eye, or blepharitis associated, or there is hyperactivity of the meibomian glands due to rosacea or acne in these patients who are young ones. So look for this. If there is farinaceous keratopathy like this, with this sticking of the mucus strands and all this, you need to work on this. Look at the lids. If they were like this, you can't do surgery at that stage. You need to treat this with the appropriate treatment with the different combinations available for these dry eyes or allergies or the blepharitis. Otherwise, you might end up with having sutures which collect mucus like that, or they collect sterile collections around them. These are not infections, these are mucus collections which are around and there are cellular reactions along with mucus collections, and they tend to loosen up the sutures earlier. So you will end up with having this irregular area, which is again not desirable because we are working to decrease those irregularities on the surface. When you remove them, the curvature might settle, but you will have this ugly scars. These are young patients, you don't want them to be cosmetically disfigured like this. And further on, you might have filament collections here where the patient will remain symptomatic for a longer time. So to get out of this, you want to first take care of the surface disease, but you also want to make sure that you have a very good edge-to-edge match while you're passing the sutures. But host rims tend to be thinner here, and that's where if you match them like this, you'll have surface problems, but you'll want to match them Bowman's to Bowman's. In which case, you will end up having regular contours. This is the left side of the graft and this is the right side of the graft, where you end up getting very good contours with small bulges between the sutures which settle out after the removal of the sutures. Talking about the scars where you can still manage to do a DALK, this was a case where we had some scar in the periphery and a DALK was done, sparing the pupillary area, and there is this deep scar which can still be managed with a DALK. Just 2 minutes. This was one with high drops, and this DALK was managed with a manual dissection, and after the surgery we can see the two edges of this thing, but with still a clear area in the donor graft. This is a localized separation in the descemetes with donor graft, which resolved over the period of time. However, this right part was good enough, and it was the pupillary area which didn't have this separation, so the ultimate outcome was reasonably good. Distortion can be, a torque sort of distortion can be there, giving this sort of stria in the periphery, which if not in the pupillary area, are still acceptable and does not hamper the visual outcome. Last but not the least, this is because of the bandage contact lens which was used and a Pseudomonas infection. So all our patients will always want to be wary of not having this, and a cautious note should be used for this. Add-on surgeries might be required later on for this graph for more fine-tuning of the optical corrections. So transplant, finally in the summary, is not to be done as long as the myopia and astigmatism are correctable to acceptable levels, optical aids are well tolerated or can be made tolerable by the other means in combinations. Cornea has a clear visual axis, there's no scarring and edema in the relevant area. Progression is under check with the help of the earlier discussed means, and there's a monitored compliance for keeping the allergy quiet. Finally, it has to be a good functional vision, which is good enough for day-to-day work for that individual. Thank you for your patient hearing, and thank you, Dr. Rajesh, for having me on this.
Thank you, Dr. Jagruti, for an excellent presentation. I would like to thank all the speakers who have participated in this instruction course. Would sincerely apologize to the chief instructor of the next course for overshooting time, and I would just request all the speakers to come forward for photograph.